Welcome, welcome, welcome. This is Kelly Cox, and I want to thank you for joining us today for the February 15th, 2023 International Myeloma Foundation Regional Community Workshop for the Midwest States. We have been doing this for quite a bit of time, and I just want to make sure you know something here, that we video replay with the slides. So if you miss anything today because your pencil broke or your pen leaked all over your hand, you can come back to this later on and look at our website and so forth. So always remember, this will be available and you'll get to see our doctors again and the nurse who are just great people. All right, I have to thank our sponsors, Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Sanofi, Takeda Oncology. Great people, been very, very busy with us and helping us out with all of our programs. Now, you're going to see this welcome to Q&A, and what you're going to do here is you can put your questions in here, and we'll do our best to get them answered by our esteemed colleagues here. Now, you open up the Q&A window. It allows you to ask questions, as I just said. If the host answers live, you may see a notification in your question and answer window. If the host replies via the Q&A box, you'll see a reply in your Q&A window. So as you can see, it's welcome, blah, blah, welcome on what to do and so forth. This is important so we can get your questions answered. As you see there, that's the circle. Now, feedback survey. I don't know if you guys have bought other products or something like that. They always say, fill out a survey about me. I want you to fill out a survey about us and our program. We like to hear from you. We have already adjusted the program this year based upon comments from people that attended our RCWs. And I want you to please take the time to fill this document out. And I think that you'll be helpful to us. Easy agenda today. It's me, Kelly Cox, Senior Director of Regional Community Workshops. I always forget to say that. The first one's going to be Rafat Abonour, one of my dear friends. He's from Indiana University College of Medicine. He's going to talk about Myeloma 101 and frontline therapy. Very important topics. Then we'll have a question and answer with the panel, and that will be with Daniel. I'll go and introduce you later, Daniel, and Dr. Kaufman, and we'll get through your questions. Then we have our little break. It's a guided meditation stretch break. I think you'll appreciate it. Then we have relapse therapy and clinical trials with Dr. Kaufman, and he's with Winship Cancer Institute of Emory University. Then life is a canvas, and you are the artist. Daniel Verena, oh gosh, Daniel, you have all these acronyms after your name. I'll just go straight to Mount Sinai Hospital, IMF Nurse Leadership Board. We got a really good program today, so get out your long legal pads, get a pen by you, get a pencil by you, and let's get things rolling. All right, Dr. Abonour, it's your turn.
Well, good evening, everybody, and thank you, Kelly, for inviting me to participate today. I just want to tell you, Kelly, that I'm not missing being with you in LA because we had similar weather to yours today. So we had high of 62. We're very glad that it's not that cold. But thank you, everybody. And I'm glad to be always working with the International Myeloma Foundation. They really have set the stage for educating patients about this, I always call it a nasty disease. Myeloma patients are the nicest patients out there, and myeloma is one of the nastiest disease. So hopefully we all can work together to understand myeloma, and one day soon we will say we are curing myeloma. So this is kind of my title, big thing, okay, but that's not what we're here for. Basically, I just want to tell you what myeloma is. And I think, I've been thinking about it for a while, and I think it's a disease where your immune system have fallen apart. That's, in a nutshell, that's what multiple myeloma. So how does that mean? What does that mean? So the reason we live a very long and healthy life is that we have something called the adaptive immunity that give you lasting protection. And what happened is that this adaptive immunity is really two components. One component, we call it the humoral or antibody-mediated immunity. So you get exposed to tetanus or influenza, you make antibodies to help fight the infection. But then you also have what we call cellular immunity, where you have these, the toxic T cells, the killer T cells that don't like, cancer cells or cells that are infected and will try to get rid of it. So what happened is that both arms of this adaptive immunity in myeloma patients not functioning well. The first part is the B cells that become plasma cells. One of these cells become malignant and produce the myeloma. And guess what? The T cells inside the bone marrow where the myeloma cells live, kind of lazy. They don't work really well, and they don't get rid of the myeloma. And the reason I'm emphasizing that, because you will hear later from Dr. Kaufman, is that we are making an amazing discoveries, and we treating patients with what we call these bispecific T-cell engager. We kind of waking up this sleepy immune system and make it recognize the myeloma and get rid of it. So really, that's what we're dealing with. So how does the plasma cells, the surveillance, the antibodies that we make, is basically we have these cells going around our body and say, I'm going to see if there's any bad things going around. So the B cells making a surveillance, they notice a bacteria or something like that, and they say, oh, we have to make an antibody. So this B cells become a plasma cells, and this plasma cells will produce antibody to get rid of the badness. So what will happen is, unfortunately, one of these plasma cells, instead of getting rid of the badness, will just multiply, become malignant, and will produce too many plasma cells that are identical. So what happened is that they produce one type of antibody. So that's monoclonal antibody. And that's really the hallmark of multiple myeloma. So basically what happened is that the cells will either produce the intact antibody. This is, look at this thing, it looks like a Y, but I call it an upside broom, because the bottom of the, the Y is that where you sort of bind the bacteria and get rid of it. And so we have two kind of light chain, one called lambda and one kappa. So your myeloma can be kappa light chain or lambda light chain. And so we follow that to help us identify how much disease you have or not. So the first thing we do to identify the monoclonal protein is that we take your serum, put it on a gel, and we run it to see if there is an abnormal protein. So on the left, you have what looks like a normal serum protein electrophoresis. On the right, you see there's a big dark band on the right. This is the gamma spike, and you see, so you have two spikes on the right, one called albumin, which is normal. The other one is the abnormal one, is the monoclonal spike. So in this case, this is what the monoclonal spike. We do immunofixation to confirm that this is the monoclonal protein. So what are the presentation? How do myeloma patients usually present, and what are the characteristics? First of all, most myeloma patients are older patients. So the majority of the patients are older than 40 years of age. And on average, the patient's age is about 65 to 69. We've been seeing a lot of younger patients for some reason. And yesterday I saw two 36-year-old patients. My youngest patient was 22. So it is disease of the older patients. Everybody will have some protein, monoclonal spike in the serum or the urine. And a lot of patients will have some bone disease. Myeloma grows inside the bone marrow, but makes the bone weaker and make it and generate holes inside the bone. So a lot of patients will have either osteopenia, osteoporosis, or lytic lesions, or they present with what we call the broken bone. You're going to find anemia in the majority of the patients. There are more male patients. slightly 59%, and obvious bone pain is present in about 60% of the patient. Some patient will present with very high calcium, and that's not good. I saw a patient she was walking her dog 3 weeks ago, and on Monday when I saw her, she said, I have, I'm kind of confused, I'm nauseated, I'm constipated, and her calcium was 17.7 milligram per deciliter. Normal calcium is 8. So hypercalcemia can be one of the presentation of multiple myeloma. And she also had a little renal failure. So she's in the hospital getting some fluid, trying to correct this high calcium. And some patient will have these bizarre things like, amyloidosis. We don't have time to talk about it, but that's some of the presentation that we deal with. Okay, so the bone disease. I told you that myeloma makes the bone weaker because it stimulates the cells that destroy bone. We call them osteoclasts. First of all, what they do is they make these holes in the bones, as you can see in the skull here. In the middle, these are the sort of dark spot, the round things. We call them lytic lesion. And that's characteristic of myeloma. They are just what is a lytic lesion? It's like a hole in your driveway. So when, grass grow in the driveway, weeds grow in the driveway, you get these holes. And that's exactly what's going on in the bone. You're just getting the weeds, the myeloma cells growing in these holes. And, if they are in the skull, it's not a big deal. But if they are in bones like the arm, they can make the arm weaker. And then fortunately, the person on the right side had a broken bone. You can see the fracture there. So that's one of the nasty thing about myeloma. And we hope that we diagnose patients before they have this kind of presentation. Now, myeloma sometimes can grow as a little tumor somewhere in the body. We call that plasmacytoma. So instead of the myeloma growing in the bone marrow in these lytic lesions, start forming little tumors. For example, on the right side here, this is you can see the eyeballs in the front, and what you're seeing behind the left eye or on the left here is a little round tumor. There's one here in the left pictures is a little tumor in the hand. So it can form plasmacytoma. Most patients will not present with plasmacytoma, but then they may develop that down the road also. Okay. The other thing is that we do MRIs to look at if somebody's having back pain. And then what we find is that we find like little tumor coming out of the spine, the bones, the vertebra. And what happened, unfortunately, in this case, is that little tumor up in the spine, pressed on the nerve, on the spine, and caused some weakness to the patient. So obviously, this is very urgent. You have to treat it right away, radiation and steroid to try to reestablish normal functions of the legs. All right. So the other test we do is a PET scan. So PET scan is really very useful. A lot of people are using PET scan now to diagnose multiple myeloma and to follow patients with multiple myeloma. It's really simple. What it is, you give a sugar that is radioactive, and rapidly dividing cells, like tumor cells, will pick up that sugar. But obviously, there are organs that like sugar, like the brain. So on the right here, you see in the skull, it's lighting up. So that's normal in the brain. What's not normal is that all these little lighting up in the bones, you can see it all over the ribs, the arms, the legs. So that's basically a patient with a lot of lesions. And what happened is that when we treat the patients, everything will turn off, except obviously the brain where you will pick up the sugar, and that's normal. So the PET scan is very important test, very useful to help us follow patients with myeloma. So the other thing is that why does myeloma occur? Because maybe there's some genetic abnormality inside these abnormal plasma cells in the bone marrow that really influence the growth of these cells. And there are tons of different changes that we see in multiple myeloma. Some we understand what they do, some we still trying to explore the importance of these genetic material. But right now, we are using genetic informations inside the myeloma cells to understand the prognosis of the patients. We have what we call the standard risk myeloma and high risk myeloma. What does a standard risk myeloma mean? Well, you have a patient whose disease expected to do very well. The patient is going to live a very long life. They're going to stay in remission for a very long time. However, the high-risk patients tend to have a shorter remission and shorter survival. And the emphasis today is how we treat patients according to their risk stratification. So there's a lot of different ways that we look at the genetic. We can just look at the chromosome and say, okay, we have 46 chromosome, that's normal. Now we have 52 chromosome. That means that we are gaining chromosome. So if you have extra chromosome, we call that hyperdiploidy. These patients tend to have a very good prognosis. If you're missing part of chromosome 17, for example, that's not good. We call that deletion Q7, deletion 17p. So that is important. So, but sometimes part of one chromosome jump on the other chromosome. We call that translocation. Some translocations are not bad, like 11, 14. But if you have translocation 6, 14, that tend to be bad prognosis. So, but all of that is probably going to be replaced by more what we call DNA sequencing, because that is going to be more sensitive and it's going to be more informative. Okay. Let me try to advance. Okay, so so we do fish analysis, and I told you why we worry about, you know, so what is high risk? And I basically deletion 17p, translocation 1416 or 1420 tend to be high risk. The good news is that only 20% of the patient with myeloma are high risk. Most of the patients tend to have what we call intermediate risk and standard risk. So it's important, and it does help your physician decide on the duration of the therapy, on the type of the therapy, on the goal of the therapy. All right? So I just want you to remember, not everybody wakes up one morning and say, oh boy, I have multiple myeloma. No. Myeloma start with a benign condition called MUGUS, monoclonal gammopathy of indeterminate significance. You just have a very few plasma cells in the bone marrow that they are abnormal, producing a monoclonal protein, but they're not causing you harm. They're not causing bone destruction. They're not causing anemia. They're not causing high calcium. They're not causing kidney failure. So, and you have a few of these cells, less than 10%. So we call that MUGUS. Not everybody with MUGUS will develop myeloma. But some of these patients, 1% of the patients per year, will have a chance of developing smoldering multiple myeloma and eventually symptomatic myeloma. So what's smoldering multiple myeloma? It's basically you have more than 10% plasma cells in the bone marrow and less than 60%, but you don't have any organ-related dysfunction, no bone disease, no anemia, no hypercalcemia, no renal dysfunction, kidney failure. So that's a smoldering. So smoldering have a higher chance of developing myeloma. It's not 1% per year. It can be 10% per year. And some type of smoldering, what we call them high-risk smoldering, may have a 25% risk of developing multiple myeloma in the first year. And so by 2 years, half of them will have myeloma. And that's where there's an area of active research to try to find how to manage smoldering myeloma. Clearly, if you have MUGUS, we're going to watch you. You're not going to get chemotherapy. If you have a smoldering multiple myeloma, there are camp of physicians who will have said to you that you need to be treated, but if you have high-risk smoldering myeloma. Some physician will say, no, let's do clinical trials. Let's find out if we're really changing the course of the disease. And then obviously multiple myeloma. Now, multiple myeloma is diagnosis is evolving. We used to say, you have to have the 10%, more than 10% plasma cells in the bone marrow, and you have to have what we call the CRAB criteria: high calcium, kidney failure, anemia, or bone disease. Well, we added 3 things now to that. Basically, having more than 60% plasma cells in the bone marrow may make you myeloma. The light chain ratio involve over and involve above 100 may make you myeloma, or having more than 1 focal lesions on an MRI or a CAT scan, more than 5 millimeters, we're going to call it myeloma. Now, obviously, this is guidelines, So if somebody has let's say the light chain ratio is more than 100, but they really have very small amount of disease in the bone marrow, about 20%, everything else is normal, you can say, maybe this is kind of smoldering, let's watch it a little bit. So, but this is now the new criteria for diagnosing multiple myeloma. All right. Now, everybody say to me when they come to the clinic, say, what stage am I? And, the question is, maybe staging is important because may help us figure out the prognosis, but really doesn't help us figure out what to treat, because we treat everybody who has symptomatic multiple myeloma with the same treatment. Maybe stage 1 have a longer survival than stage 3, but these things are changing. So I ask my patient not to really focus on the staging, but this is it. You have it here. Basically, stage 3, you have bad cytogenetics, you have high LDH, you have high beta-2 microglobulin, then we're going to call you stage 3. Basically, the goal should be, let's get rid of the myeloma. That will be the best thing you can do for the patient, is to try to get the patient into complete remission. I think you can overcome the issue with staging. So don't panic if your doctor told you you have a stage 3. I think with the right treatment and the right cytogenetic, you're probably going to be fine. All right. This is a slide just to show you the rate of progression in MUGUS on the bottom. You can see most patients by 20 years, they still have not progressed to myeloma. However, the smoldering myeloma, the majority of the patients by 20 years will have symptomatic multiple myeloma. All right, so that was myeloma 101, basically, what is the cells involved, how we test for it, and how we stage it, and how we classify it based on risk. But now we have myeloma, so how are we going to treat it? You have 2 things, when you're thinking about myeloma. You have somebody present with very high calcium, kidney failure, anemia, bone disease. You have to control the symptoms. So you have to manage these as soon as possible, get the calcium normal, control the pain, make sure the kidneys are functioning fine. So that's called symptoms control. And so your physician need to pay attention to your symptoms, try to manage it. Then you have to get rid of the cancer that causes symptoms. So basically you need to get rid of the myeloma as soon as possible so you can start healing as soon as possible. And obviously, we need to make sure that when we treat the patients, we're paying attention to the side effect and managing toxicity. So really, we need to make sure the patient is living the longest quality life. So that will be how we pick up a regimen that is suitable for the patient. All right. Now, what's emerging is that how much you get rid of myeloma is very important. So in the past, we used to say, okay, just getting rid of about 50% of the myeloma can provide you quality of life. But the thing about it is that if you get rid of just 50% of the myeloma, that's the first little line on top here, you can see that you left a lot of myeloma behind and the patient is going to relapse quickly. But if you start getting rid of more myeloma, the line's going down and deeper, and you're getting to maybe 1 or 10 myeloma cells left behind, you have very little myeloma left behind. It's going to take much longer for the myeloma to come back, and hopefully will never come back because your immune system is awakened and can get rid of few myeloma cells that left behind. So really the depth of response is very important. Getting a partial response today is really not a good thing, especially when you have great treatments available to the patient that are can be delivered safely. Okay, so depth of response is very important. Getting rid of myeloma is very important because then you don't have to deal with relapse and you don't have to listen to Dr. Kaufman, because who wants to be relapsing and who wants to hear about, you know, these new things? Let's get it right up front. That's what I hope, that we always try to get it right up front and make sure that the patient get a lasting remission. All right. Well, this is the evolution of multiple myeloma. So some of us, you know, on this call have been around this, you know, sort of natural history of drug development of myeloma. We're very lucky. We're very blessed that we have had this change in the management of patients with multiple myeloma. When I started, we have VAD, which is vincristine, adriamycin, dexamethasone. You're giving tons of dexamethasone, 4 days on, 4 days off. And then you give them high-dose melphalan stem cell transplant, and you just do nothing. But now, you know, the new things are just, you know, first of all, you know, we have better drugs. You know, we have the bortezomib, we have lenalidomide, we have combination, because we did, you know, just 2 drugs regimen, you know, like Velcade and dexamethasone. That was not enough. We added Revlimid to it. We get a great cytoreduction. Now we're adding monoclonal antibodies, and we have different monoclonal antibody. We have different proteasome inhibitor. We call it Kyprolis. So there are different 4-drug regimens on the bottom. And then we do autologous stem cell transplant on most patients. Some people say maybe will transplant not be needed. I think we still have to prove that. You know, for now, I think it's probably very important for the majority of the patients. And then the maintenance story, for a long time, we just had the Revlimid, the lenalidomide. Now we can add monoclonal antibody to it. We can add other stuff. And then, you know, so it's really improving significantly. And obviously, the rescue part, when the patient relapses, you're going to hear from my friend Jonathan Kaufman here shortly. Okay, so tons of options, tons of options. So how do people do with these tons of options? So first of all, I think combination therapy continues to prove superiority in providing long remission and long survival. Okay. So you can't really say, I just want to take Revlimid, I just want to take Velcade. It doesn't work. I mean, the data is clear. Combination therapy produce the best results. And the good thing is that you guys are in a good place because we have options. So when we started, we're going to give everybody VAD. You know, a few years later, everybody's going to get Revlimid next. But now we have options that suit you and can be based on what you have. I mean, do you have neuropathy? Do you have kidney failure? We can design a treatment that is very suitable for you. And I think the backbone of therapy right now is Revlimid, Velcade, and steroid dexamethasone. It's been very effective, tried against several things. But now people start adding to it daratumumab. Or you can say if the patient has neuropathy or something like that, you can do daratumumab, lenalidomide, and you know, that's based on a large study called the Maya study. But I really think, you know, you should be patient because we're going to have more combination coming up that are incredible. So the first trial is called the Griffin trial. This is a trial. I'm just going to, you know, these slides may be a little complicated, but I'm going to try to explain them. Basically, what I'm going to go now through several trials that proved that, for example, 4-drug regimens, daratumumab, Revlimid, Velcade, lenalidomide, and bortezomib, and dexamethasone is really a good regimen. Now they have 24 months of follow-up with maintenance. So, and I think, Jonathan, and you on this somehow. Yeah, I think you're probably one of the author. So let's see what happened. This is a really trial was, okay, is Revlimid, Velcade, Dex the best treatment, or should we be giving daratumumab? And can we use daratumumab in the induction, the first 4 months of treatment, in the consolidation, the subsequent 2 cycles, and in the maintenance? And the maintenance was Revlimid versus Revlimid. So this was a trial saying, okay, we need 4-drug regimen for about 6 cycles, and then we can see if giving daratumumab in the maintenance setting can improve the outcome. So what happened in this trial? First of all, on the left in the purplish color, what you're seeing here is the result of Revlimid, Velcade. And basically what happened is that everybody responded, but the depth of response, how many people getting what we call the stringent complete remission? That means all of the myeloma is gone. You do a bone marrow biopsy, doesn't have a single myeloma cells in it, and you do a free light chain assay, and the levels are normal and the ratio is normal. And look at this. I mean, this is incredible. After 2 years of maintenance in the daratumumab arm, 66% are in stringent complete remission, compare in the Revlimid, Velcade, dexamethasone, 47%. So the first clue here is that 4 drug regimens followed by maintenance with a monoclonal antibody giving you the best depth of response. And I told you earlier, depth of response does translate to better outcome because you're leaving less myeloma behind and taking it much longer to relapse, okay? Now, and this is also looking at MRD testing. You're gonna hear about this a lot. MRD testing, minimal residual disease undetected or negative. And you can see here that in depends on the assay you're doing. Majority of the patients with DARA arm, 64%, had a MRD negative. If you look at the very sensitive part, is about 36%. So you're getting rid of a lot of myeloma to a really minimal residual disease that is either undetected or negative. So good news, compare to the Revlimid, Velcade, Dex, it's much less. So 4-drug regimen, deep response, and more MRD negative, okay? And the patients are living longer. I mean, look at that. I mean, at 3 years, there are more patients surviving. So I think the take-home message of that trial is that I think 4-drug regimen produce a deep response, deeper response than 3-drug, and with each step from the induction, consolidation, maintenance, transplant, you're getting a deeper response. And it is feasible to add the monoclonal antibody to lenalidomide. They didn't see any increased toxicity, no side effect. So I think we are, this is a very good trial. Further phase 3 study may be helpful. We will find out, all right? So this is really work that I love by my friend Luciano Costa from Alabama. And I call him Master Luciano. I think he deserved that title because I think he is, single-handedly trying to say, listen, guys, we told you the depth of response is very important. Why don't we guide the therapy based on whether you get minimal residual disease or not? So this is called the MASTER trial. And so what did the MASTER do? The MASTER said, okay, I'm going to take everybody who has multiple myeloma. I'm going to give them induction with 4 drugs, daratumumab, carfilzomib, lenalidomide, and dexamethasone. So Darzalex, Kyprolis, Revlimid, dexamethasone for 4 cycles. And then I'm going to do a stem cell transplant. And after the stem cell transplant, he did something that is so brave that nobody has been able to say, I'm going to do. It said, okay, if you are MRD negative and sort of sure twice, MRD negative, guess what? We're not going to do anything. We're just going to put you on active surveillance. We're going to see if you're going to relapse or not. But if you still have residual disease, I'm going to give you another 4 cycle of consolidation with the same thing you started with. And after that, I'm going to do a bone marrow. Are you MRD negative or not? Negative, surveillance, no more treatment, no maintenance. But if you still have disease, you're going to get consolidation. And after the second consolidation, if you still have disease, you will go on maintenance Revlimid. So that's pretty darn good. If I'm a patient, I'm signing up for this because I want to stop treatment. Like Joe McHale, my friend, will always say, the best drug is what? No drug. So that's what the master Luciano was trying to do. So he basically showed, number one is that even with high-risk cytogenetic, if you have one of them or none, you're going to do really well. You're going to stay in remission for a long time, and you're going to live a long time. Obviously, the difficulty still is that the high-risk patient, when they have a couple of them, you have the translocation and you have the P17 deletion, you may not do as well. So this is where I think we need work done. But for the standard risk patient, showed that the results are really great. So I think the conclusion from that trial is that next generation sequencing, MRD response adaptive therapy was feasible in the majority of the patients in multi-center. It was not just done in Alabama. There were 5 other academic centers that joined them on that. And patient with standard and high risk have similar depth of response and low risk of MRD resurgence. And so basically we believe that quadruplet therapy is very important and maybe will provide a great result for the majority of the patient. It's the ultra high risk patient. The people who have multiple high-risk cytogenetic may not do as well. And obviously, these are the patients we need to investigate. Okay, I think I am going probably over time here. So you can use another antibodies. You don't, there's trials with isatuximab, lenalidomide, and bortezomib. So that looks really good. This is a trial that showed that adding a CD38 antibody to RVD is a good idea, giving you more MRD negative results, deeper response, and again, the patients responded quite well with the combination. So, and the side effect profile was not unpredictable. So basically what I would like to say is that upfront therapy is great, evolving. I think adding CD38 antibody to VRD or KRD is feasible with limited side effect. It deepens the response, increasing MRD negativity, and basically improving the time without relapse. And I think may overcome one high-risk cytogenetic abnormality. We still have to work on the ultra high-risk patients. What about transplant? I mean, I think that is, questions continue to evolve. Right now, I don't think anybody has proven that we don't need it. Until we have the right trials, we need to be paying attention to that. And going back to my friend, the master Luciano, he's actually having now master do to the DREAM trial. And the DREAM is what, guys? What is our dream as a myeloma doctor? Is to cure myeloma, to end myeloma. And I think his title is basically, and Twitter, I think is End Myeloma, isn't it, Jonathan? Yeah. So basically what he's gonna try to do is, guess what? He's gonna bring for patients who are not responding well, some of the novel therapy you're gonna hear from Jonathan about, the bispecific T-cell engager. Very bold, but I think if you're gonna get rid of myeloma and you're not gonna have to deal with relapse, refractory, ugly myeloma, guess what? Get rid of the myeloma, not have any myeloma cells left behind, because when they're not around, they're not gonna mutate. when they are around, they're going to mutate. They're going to become, aggressive. So I think this bold approach to try to use some of the novel therapy, the bispecific T-cell engager, early on for patients who don't achieve minimal residual disease I think, is very exciting. So, I think what we need to do is at least some of my buddies, cyclists, myeloma patients, and basically what they're saying, we're going to get rid of you, myeloma. So with that, my friend Kelly, we can take questions.
Yes. Look at those guns on you, Rafat.
Photoshopping is really great, isn't it?
Yeah. It took 10 off my life. Hey, how long have you been biking? Or what are you doing there? Is it something you do every October?
Yeah, this is 19 years of miles for myeloma,
yeah.
So we used to be running and cycling, now it's cycling, and now it's just eating. No, just
yeah. Well, as you can see by my size, I haven't skipped a meal. Anyway, let's see. What is FDG suppression? Did you cover that? FDG suppression.
When we do a PET scan, we use a radioactive glucose, FDG, and that's basically get picked up by the rapidly dividing cells, tumor cells. So that's, just sequenced by the tumor cells, but some normal tissue like the brain likes it, goes through the heart, you're going to see the heart lighting up, and then what the dye, you don't need it, goes through the kidney, so you're going to see it in the kidney, you're going to see it in the bladder. But basically, I don't know if that's what the question is.
Yeah, I'm not sure about that. And then another question from the same person. So I've already had RVD and SCT. Should I ask my MM specialist to add DARA to my 10 milligrams of Revlimid? Let's see, it just moved. Let's see.
That's a very good question. So you already got your induction, transplant, and now you're on maintenance Revlimid. Would you add DARA to it now? Obviously, if you haven't made the decision to add it, you could be guided with what's your disease status. Are you in complete remission? Is your bone marrow clean of myeloma? Then I don't see a reason to add the DARA. But if there's residual disease, you can discuss it with your physician and consider adding it. Depends on how much residual disease add. But, I think it's a clinical judgment.
I see.
And we're still doing the trial. We're still trying to figure out if DARA Revlimid as good as Revlimid. We have a national study that, sponsored by all the cooperative group looking at that. So I encourage patients after they get stem cell transplant, before they go on maintenance, to talk about it to their physician, say, can I go on a SWOG study that looking at DARA Revlimid versus Revlimid?
Okay.
What do you think, Jonathan?
Yeah, Jonathan, I want you to add to that.
Yeah, so for our patients who have standard risk disease, we also have used the 4-drug induction therapy. And despite the fact that we participated in the study that did the DARA Revlimid maintenance therapy, we were not convinced. We have not been convinced, and we're in a maintenance setting, we really are waiting on phase 3 data to make the decision. So for most of our patients, even patients in VGPR, we are continuing single agent Revlimid as our maintenance therapy. There's very good data for it. We worry about, we haven't seen the long-term outcomes yet, both from how well it works, efficacy, and the side effects, toxicity. And so we're holding off. I think there's more and more 2-agent maintenance therapy going on. So I think it's reasonable to discuss it, but my recommendation for most patients that are in your exact same situation are to continue the single agent Revlimid.
This is an interesting question. How do you see lesions on the skull if the brain lights up on the PET scan?
That's a very good question. You just have to look at the slice, and you look at the bone so you can see them. But Yeah, I mean, it depends. You have to look at the edge of the, this the brain, the bone surrounding the brain. But if it's not easy. It takes special slicing of to take a look at it. But you can see them sometimes. Yeah.
Okay, good. Well, let's move on to our relaxation session. I want to thank Dr. Coffin and Dr. Abonour. Dr. Coffin and Abonour will be back after this, and so will Dr. Vereen, I guess I'd say. And I want you to fill out the question and answer window, and you're also going to remember this through the survey. So let's keep going, and the next session is wellness. All right, everyone take a stretch. Don't drink any coffee and drink some water. Woo, I almost missed my cue there. I was taking a nap from my relaxation time. I hope that helps you out. I'd like to thank a colleague, Kelly Dorwitz, that puts that on. It's on our website too, at myeloma.org. I think that's very important for you to relax. You can hear better, try to calm down, and look at things from a different perspective will always help you. So we're going into the home stretch here. Another dear friend, Dr. Kaufman, will be doing relapse therapy and clinical trials. And this is some very important topics. It's going to look at the future of myeloma. So Dr. Kaufman, start your engines.
Okay. Thank you, Kelly, and thank you to the IMF, and thank you for everybody who's here tonight. I'm going to talk about relapsed treatment in myeloma. I'm from Emory in Atlanta, and I've been doing these with Kelly and team for a long time. And Kelly has promised me that the next time we do this, we're going to be in person. So I really look forward to seeing all of you in person the next time we do this. When we think about progression from our standpoint, the more scientific medical standpoint, the International Myeloma Working Group came up with narrow and strict definitions about what exactly progression means. And then there are other types of progression. There's the definition of progression by the International Myeloma Working Group, IMWG, and then there's clinical progression, which is similar to how people are diagnosed with symptomatic newly diagnosed myeloma using the symptoms of myeloma or the CRAB criteria. And then as we go through, we'll come to realize that every individual patient's myeloma progression, and not everybody progresses, but we are frank that most people with myeloma will progress, even if it's not everybody. Everybody's is different. Everybody's goes at a different pace. How we respond to relapse is different, and there's a whole set of reasons. So if you look, biochemical progression means let's say you have achieved a complete remission, or let me rephrase that, a complete response. That means your paraprotein is 0. The urine paraprotein is 0. The serum free light ratio, the serum free light chains are normal, and the ratio is normal. Progression means that the paraprotein has gone up by 25% from its lowest, but it's a minimum of 0.5 grams per deciliter. So we don't even call it progression until, if someone's has had a complete response, until the paraprotein reaches 0.5 grams per deciliter. And excuse me, I will use the word paraprotein, M protein, monoclonal protein, M spike. I will use them interchangeably throughout this talk. They all mean the same thing. They're all our way. It's the way that we measure. It's our easiest way of measuring the amount of myeloma in the body. Some people make an M protein. Some people make an M protein in their serum or their blood and their urine. Some people don't make an M protein in their serum or blood, and they only make the light chain portion of it. When you saw the graphical representation in the talk by Dr. Abonour, where he showed the immunoglobulin. The immunoglobulin, again, is the medical term for antibody. When he showed that immunoglobulin, he showed two paired pieces, and the longer piece is the heavy chain, and that smaller piece is the light chain because it's less heavy, as in light. And some people, their myeloma only makes the light chain portion of it. And so we have all these rules about how we can tell if somebody has biochemical relapse. And then there's something separately called clinical relapse. And clinical relapse, in fact, can be ahead of biochemical relapse. There are some patients who develop a new tumor, whether we pick it up that on a physical exam or one notices it or it's seen on a scan without having the biochemical relapse. That's relapse. Some patients, on the other hand, will have concurrent biochemical and clinical relapse. As the paraprotein is rising and it gets to that number, that 25% increase from the nadir, or that 0.5 grams per deciliter, concurrently, they'll have the hemoglobin will drop and become anemic, and that's clinical relapse and biochemical progression together. And then thirdly, there's sometimes a patient can have biochemical progression, and so we will document and we will say you have progression of disease. What you're doing isn't working anymore, or it's not working well, but there's no clinical relapse. And a lot of times in that situation, we'll continue with what we're doing. We will continue therapy. And I tell patients all the time this: there's a moment between when we see evidence of relapse, and in the future, there's a moment when there's a broken bone, or kidney problems, or a bad pneumonia that makes you go in the hospital. And so our job, and what I'm going to spend the next 10 or 15 minutes talking about, is how do we figure out what that magic moment in time is to start therapy. Now, some patients will say, I want to be treated as soon as I can. And we listen to that. And some patients say, if I feel fine, I want to stay away from treatment as long as I can. And we'll listen to that also. And so while we have these guidelines, the most important decision about treatment is the decision between you and us, and using the guidelines to help us. All right. I'm going to reiterate a lot of things. Not every relapse needs to be treated with the same urgency. A patient who has a very high calcium, who has a tumor compressing a spinal nerve, whose kidneys are failing, needs to be treated today. And we'll treat things today. Again, as I noted, in the exact opposite, the patient has a slowly rising paraprotein, PET scan was repeated and negative, no anemia, no high calcium, no kidney problems. We can keep an eye on things. And so my general approach is that we get everything out of each line of therapy that we can get. We get every bit of mileage out of each line of therapy. And so I don't stop. In the absence of, I'm worried that something bad is going to happen, we don't want to change too quickly with a small variation in the labs. And so we try to take a deep breath when we see this. We recognize it's not what we want, but a relapse or a reoccurrence of a paraprotein represents a change in treatment. It does not represent a change in treatment. Now, if you're on maintenance therapy and you're getting labs every 3 months or so, and the protein comes back, the doctor might, instead of making a change, might say, hey, look, we're going to keep an eye a little bit closer. So that's a change that's commonly made. But just because there's the recurrence of a protein or even the biochemical relapse does not necessarily mean that a change is absolutely needed. So how do we figure out what to do next? And again, the single most important thing is the conversation that you're having with your doctor. And what we're looking at are prior treatments. What have you had previously? Are you off therapy and you're not refractory to any drugs? And what have you been exposed to previously? How long was your initial treatment duration? We recently presented data that in patients who get second-line therapy with a combination of Pomalyst and Darzalex or daratumumab and dexamethasone, if they had Revlimid maintenance for 3 years, they did very well with that therapy. If they had Revlimid maintenance for shorter than 3 years, that didn't seem to be the right combination for them. So we use the knowledge of what has happened with the patient to help us make the next decision. And then the other thing that we think about when we're trying to get a better understanding of the disease, how aggressive do we have to be in our recommendation? Was the duration of benefit longer or shorter than what we saw previously? And that helps us. That helps us understand your disease better so that we can give you better advice. What about you? How are you doing? That's patient-related factors, performance status. How much of the day are you living normally? Do you go to work every day? Are you golfing 4 days a week? Are you doing all your normal activities? Or are you a little tired? You can't do all your normal activities, but but you don't have to spend any time resting? Or are you at home, resting a part or majority of the day? That's performance status. Age, I think, to be honest, is an extremely small part of our discussion. We have to know age because it helps us put things in context like kidney function, but age in and of itself very rarely makes us make major decisions. Comorbidities. What else is going on? Do you also have heart disease? Do you also have lung disease? Do you also have liver disease? Do you also have kidney disease? We need to know that. What side effects have you had previously? When you had Velcade, did you develop neuropathy? Do we need to think about that? If you had Revlimid in the past, did you have a lot of side effects from Revlimid? And those things help us. And then it's compliance and what you're willing to do. Sometimes we have patients who really, they're not good with taking a medication every day. And no matter, you try, your family tries, the doctors try, it's just not good. That's somebody that we're going to think, maybe let's think about a drug that we can give you in the clinic, and you don't have to worry about taking this really important, expensive medication every day. So those are the types of things. And there's other patients who say, I just don't want to come to your infusion center. Give me anything that I can take at home. And then we think about disease factors. Again, we're putting all this together. Does somebody have extramedullary disease? Extramedullary disease, tumors outside of the bone, or are there circulating myeloma cells in the blood outside of the bone marrow? We now at least have one drug, not yet approved for myeloma, but clearly very active in going through the approval process, that specific genetic alterations, the 11-14 translocation, can help us make decisions about what to do next. And just like Dr. Abonour said about We don't have time today to talk about amyloidosis, which is a whole hour on its own. We don't really have time today to talk about 1114 and the use of drugs that target 1114. But that's the type of thing that we need to know about at relapse to help us make decisions. Is there a very high tumor burden? Higher tumor burden makes us think that we need to do something differently than a relatively low tumor burden. And finally, is there myeloma-related renal failure? Or is there a myeloma-related tumor that's about to have a fracture? Those are the types of things that help us make decisions. So we know through many clinical trials, and the reality is the only way that we have any access to any of these medications is participation in clinical trials. So if you've ever participated in a clinical trial, I thank you. If you're considering participating in clinical trial, I strongly encourage it. If your doctor never talks to you about clinical trials, please ask. Again, we need to think about this concept of, have you ever had this drug before? Are you refractory to this drug? And refractory to this drug has a few definitions, but I think the current best definition is that the myeloma got worse while you're on the drug or within 2 months of stopping it. That's what I consider refractory. And then in terms of where are we with options? We want to give at least something new to treat that the patient you have not been exposed to before. If somebody in a large part, and this is not 100%, but in a large part, if you're refractory to that drug, we typically will switch agents, and there are some situations where by taking a drug, and this is maybe not in later relapses, where we could take a drug that we had before that stopped working and add in a new drug that can overcome that resistance. So there's a lot of research into that. And so it is, while it's not the first choice, oftentimes we will use a combination and reach back into a drug that one had previously. Okay. So this is becoming repetitive, but I'll just say it again. One size does not fit all in patients with relapse. Knowing prior treatment's helpful. Knowing your sensitivity to prior treatment's helpful. And knowing toxicities from prior regimens is very helpful in making decisions about next therapies. Again, we talked about patient factors. We talked, and then so what do we consider? In general, we want to do combinations. We've done many trials that show that combination therapy is superior to single agent therapy. Having said that, there are certain times when a single agent with dexamethasone is better than is right for an individual than 2 drugs with dexamethasone. And again, I already mentioned we have a lot of oral agents. We have a lot of infusional agents, whether they're intravenous or subcutaneous, through the vein or under the skin. So again, not every patient is the same. Again, age is not the most important thing. Thinking age maybe as a risk factor for having other comorbidities is important, but age in and of itself isn't. Again, because of heart disease or kidney disease, we have to know these things. And then obviously we talked about patient preference. Oops. So we talked about these things. What do we need to consider? When is rapid reduction needed? If somebody has sensitive kidneys, we need to think about kidneys that don't have that wouldn't affect the kidneys. And again, we talked about right now, there's really only one specific genetic abnormality where we can target things. We have a lot of ongoing research to try to ask the questions, can we really subdivide patients? And so we can provide you with all the factors I talked about with the specific cytogenetic abnormality, what's the right drug for you? We don't have that across the board in myeloma. We do have that with the 1114 translocation. Myeloma is not a single disease. And your individual myeloma could change over time. Typically, patients who have high-risk myeloma, who are progressing early after initial therapy, who have tumors outside of the bone marrow, who have specific high-risk alterations, really need more aggressive therapy. And oftentimes, I'll say, we need to meet the aggressiveness of the myeloma with the aggressiveness of our therapies. And then there are rare times when the myeloma is so out of control that and the blood counts, and there's not a trial available, that we actually go back to older chemotherapy that we've used as a temporizing measure. We try to avoid this because a conventional older chemotherapy is associated with a fair amount of toxicity, but sometimes it helps us to get out of a fire. And then we can regroup, take a deep breath, and then rethink about our newer, more targeted agents. Speaking of newer and more targeted agents, this is the current approved list, I believe, and you'll see here we still have thalidomide. Thalidomide and lenalidomide and pomalidomide live in a group of drugs called IMiDs. For many years, we didn't know how IMiDs worked, but luckily the scientists have taught us, and we now know the specific target of the IMiDs within the myeloma as well as the immune cells, cereblon. And so now this group of drugs, there's multiple next line group of drugs, iberdomide and mezigdomide. These are all names that you're going to hear. We're now calling them CELMoDs instead of IMiDs. Lenalidomide has been a mainstay of therapy for now going on 20 years, very commonly used in the maintenance setting. And what we've learned this a long time ago, and recent data has confirmed this. If somebody is refractory to lenalidomide at maintenance doses, and refractory meaning progressing while on it, then that patient is refractory to lenalidomide. And it's very unlikely to significantly benefit from raising the dose. So patients who are refractory to lenalidomide can get pomalidomide. We know that pomalidomide is effective when lenalidomide stops working. We have proteasome inhibitors, bortezomib or Velcade, carfilzomib or Kyprolis, exacinib or Ninlaro. Right now, bortezomib or Velcade is given under the skin subcutaneously. Carfilzomib or Kyprolis is given intravenously, and exacinib or Ninlaro is given orally. At their highest doses that are approved by the FDA, I would say that the most potent is probably carfilzomib, then Kyprolis, then Velcade, then Ninlaro. Now, oftentimes patients can't tolerate those doses at the highest levels. And if we can find somebody where Ninlaro works, and then using an oral medication that's given once a week seems better to me than having to come in once or twice a week to get an intravenous medication. We now have three what are called naked antibodies. Naked antibodies is that there's nothing attached to them. There's nothing added to them. And so the antibodies are daratumumab, or otherwise known as Darzalex or Faspro. Daratumumab or Darzalex is the brand name that is given intravenously, and Faspro is the brand name that's given subcutaneously. Isatuximab is sarclisa, that's given intravenously. Daratumumab and isatuximab target the same thing, anti-CD38 on the myeloma cell. All myeloma cells have CD38 on it. And so these antibodies are anti-CD38. They work in a very similar way. And and in a large part, if daratumumab stops working, then isatuximab won't work. If isatuximab stops working, then daratumumab won't work. And people say, well, which one do you like? And what I tell everybody is that I view this as Coke versus Pepsi. You like Coke or you like Pepsi? You know, it's really up to you. There's one right now has two ways of giving it. One right now maybe is a little bit less expensive. At some point, the dosing regimen may or may not be more convenient. They're very similar, and it's really what your doctors and is most used to giving. That's going to be the right drug. Elotuzumab or Implicity is another antibody. It targets a different protein called SLAM F7, and I'll just tell you, Darzalex and Sarclisa have single agent activity. Elotuzumab doesn't, and only is effective in combination with either pomalidomide or Pomalyst or Revlimid. And so we don't use or likely the other CELMoDs or the other IMiDs. We don't use it with the proteasome inhibitors. We now have what's called an XPO inhibitor, and I'll go over the mechanism of how this works. This is selinexor. Selinexor or Xpovio is an oral medication. When it was first studied and approved, it was given twice a week at high doses. And while it was effective, it had a fair amount of side effects. And just like almost every drug we use in myeloma, we learn more about the drug after it's approved initially than before it's approved. The approval dosing strategy is a narrow strategy to get drugs approved. And it's not the end all and be all. And again, we learn so much more about a drug after it's approved than we learned before it's approved. So now selinexor is given once a week. It's given at lower doses. It's often given in combinations with Velcade or Kyprolis or Pomalyst. I wrote little lines through the belantamab. The ADC is called an antibody drug conjugate. Antibody drug conjugates, it's like an antibody. So the antibody goes and he binds the myeloma cell, and then attached to it is a chemotherapy. And the myeloma cell will then take in the drug with the chemotherapy. And once the drug with the chemotherapy is inside the cell, the chemotherapy will come off and go and do its job and try to kill the myeloma cell. And so this belantamab or Blenrep had a new target. We've already talked about CD38. We talked about SLAM F7. This is our third antibody conjugate called BCMA, B cell maturation antigen. And as you remember in the beginning of Dr. Abonour's talk, he talked about the cells going from B cells to plasma cells. Once they become plasma cells, they all have this target called B cell maturation antigen. And so belantamab was approved based on a study that showed about 30 to 35% of patients responded to therapy. So about a third of the patients who got the drug responded. Great news for the third who responded. That leaves 2/3 who didn't. The third who responded, the response almost lasted a year. So it was just about a year. So for patients who didn't have anything else, this was really helpful. The downside of Blenrep was it caused what we call keratopathy, problems with the cornea. vision problems. And so there was a lot of rules about how to get it. You had to collaborate with an ophthalmologist or an eye professional. You had to collaborate with the infusion center. And so we were able to give it. And BlendRep, the folks who make BlendRep designed a clinical trial to try to say, hey, look, we know this is active after patients have had every therapy, but we want to ask the question, is it better than therapies given in the third line of therapy, not the fourth and fifth lines of therapy? And so they did a head-to-head study of BlendRep versus Pomalyst and dexamethasone, and they found out that how long the drug worked was essentially the two drugs were not different. So it worked, but it wasn't better than pomalidomide or Pomalyst and dexamethasone. And so because companies who get approval for drugs based on response rate have to prove to the FDA that it's better than something else, and it failed to do so, so the FDA brought the drug off the market. I have no knowledge of this, but I personally believe with further research, refining of the dose, different combinations, different studies, we're going to have BlendRep back. But for right now, this drug is not available unless you were on the drug before it was taken off the market, and that your doctor has applied for specific research programs to continue the drug. All right, so now I'm going to get to the exciting stuff in the relapse setting, what we call CAR T cells and bispecifics. And I have slides about CAR T cells. We have two CAR T cells. One is ide-cel or Abecma, and one is cilta-cel or Carvykti. And I'll show you details about that. And then just 3 or 4 months ago, we have the first approval for a totally new type of drug called a bispecific antibody. And the first one is teclistamab. And again, you'll see all 4 of these drugs, this drug that's no longer around, and these 3 drugs are all targeting BCMA. From a research standpoint, we have new targets that we're looking for outside of BCMA. Okay, I'm moving along here. That was a long slide, sorry. I need the relaxer again. Can we get a minute on the relaxer? Kelly?
Sure thing, Jonathan. Sure thing.
All right, everybody take a deep breath. That was, all right. So IMiDs, how do they work? I mentioned that for a long time, we called them IMiDs, immunomodulatory agents. You asked how they worked, and they said it modulated your immune system. And now we know what it does. It attaches to this very complicated system called the cereblon E3 ubiquitin ligase complex. But what that does is that it kills myeloma cells and it activates the immune system. And so this is how all of these IMiDs work. And we have a new, and I told you about this new IMiD called iberdomide. And iberdomide, we're learning, can work when Revlimid and pomalidomide or Pomalyst stop working. So a lot, and then we have mezigdomide. So we're gonna have next generation of all these targeted agents. Proteasome inhibitors. You guys, again, I mentioned 3 proteasome inhibitors. Velcade, Kyprolis, and Inlara. They all work essentially the same way. Again, as was mentioned in the Myeloma 101 talk, the job and life of a plasma cell, and hence the job and life of an abnormal myeloma cell, it's a factory that makes antibodies over and over and over again. And the antibodies are proteins. And those proteins have to get out of the cell. And they either have to leave the cell or they have to be broken down. And the proteasome is what breaks down proteins. And if we inhibit the proteasome, then all this extra protein that's made in the cells hangs out in the cell, becomes toxic, and the cell dies. And so all of these work by inhibiting that proteasome, inhibiting the recycling bin within the myeloma cells. And myeloma cells are uniquely sensitive because they're protein production factories. daratumumab, and the same thing is going to be for both daratumumab and or Darzalex, Faspro, isatuximab, Sarclisa are work in a very similar way. These are antibodies. So we talked about antibodies coming from myeloma cells. We talked about the M protein being an antibody. These are therapeutic antibodies. These therapeutic antibodies bind to the myeloma cells. They can kill the myeloma cells directly, but likely more importantly, they coordinate the immune system to attack the myeloma. And they get all of these different immune mechanisms to attack the myeloma. And so, again, these are immune therapies that allow us to kill the myeloma directly and coordinate the immune system to recognize the myeloma as abnormal and kill the myeloma. So I'm going to skip this slide. All right, we talked briefly about selinexor. The selinexor is an interesting drug. We have inside of the nucleus where our DNA lives, there's all these proteins that go from the nucleus out of the nucleus. On this screen, okay. Sorry about that. The selinexor is expovia. Cells come in and out, the proteins come in and out of the nucleus. What expovia does is it traps the proteins in the nucleus that will help kill the myeloma cell. And so it's inhibiting the proteins that are going to kill the myeloma cell from getting out of the nucleus. So that's how it works. Again, in combination at high doses in patients with multiply relapsed disease in combination with dexamethasone, it works in about 1 in 5 patients. But we don't give it like that anymore. In fact, outside of a clinical trial, I've never given it like it was initially approved. Most of us will give it in combination at much lower doses with either Velcade or Kyprolis or Pomalyst. We already talked about belantamab, and I guess I probably already spent too much time talking about Blenrep, which is no longer an approved drug, so I'm going to move right on from Blenrep. All right, CAR T cell. This is very exciting. CAR stands for chimeric antigen receptor. And going back to myeloma 101, we talked about B cells and T cells. B cells are the ones, B cells become plasma cells. B cells are the ones that make antibodies. And so, and then T cells are the attacking arm of T cells are the attacking arm of our immune system. And so these brilliant scientists have made a protein and in the simplest way, the way that I think about this is that on the outside, it looks like a B cell. So it targets, it can grab on, it can grab on to a cancer cell. On the inside of this, it looks like a T cell. So it can activate the T cells. And so what we do is we do a pheresis of the blood, similar to pheresis that we had with stem cell transplant. Blood comes out of an arm or a line, it spins through a machine. That spinning separates the cells based on their weight properties, and the white blood cells, where all the T cells are, get taken away. In contrast to what if you ever had stem cells collected, there's no shots beforehand, there's nothing. There's no shots beforehand. You just go in there 3-4 hours on the machine, and then you get your blood back, and they take away that thin layer, the Buffy coat, and then we send that to a laboratory. And that's where these are basically, the word is transfected. We introduce this new genetic material that turns into this CAR protein into these cells. And then we grow these cells. And we grow in a dish. And then these cells are reinfused. before the cells are reinfused, there's 3 days of 2 chemotherapies. And in contrast to the chemotherapy that one gets before a transplant, this chemotherapy, its job is to get rid of your own immune cells so that those new CAR T cells that are going to target the myeloma have, whether it's physical space or conceptual immunologic space, they have space to get into your body and grow. And then these CAR T cells attack the cancer cells. And so this is CAR T cell, requires 3 days of 2 chemotherapies, 2-day break, infusion of the CAR T cells, and then a 1 to 2 week time period where we're monitoring very closely for side effects. We do it as an inpatient mostly. Some people figured out how to do it as an outpatient. 2 major side effects, one, and they're both related to the immune system getting overactive, which is one is called CRS, cytokine release syndrome. It's like having the worst flu, but it's not a bug. It's your body's response to this incredibly strong immunologic interaction. And the other one is called, we call it ICANS. I call it neurologic toxicity. Word finding problems, confusion, difficulty writing, worst case scenario, seizures, or even coma. And that's, again, a little bit less well understood immunologic overactivation. All right. And so this was, and this is another way of looking at this. One gets leukapheresed, that's the cells come out, spend a month manufacturing, 3 days of chemotherapy, infusion, and then getting better, hopefully for a long time. All right, our last drug, and I don't have a good cartoon for this, and I apologize, is teclistamab. Think about that antibody I talked about that was showed earlier. It had 2 parts. It had 2 parts. Now this is different. This is called bispecific. So there's 2 things. One is the thing that attaches to the myeloma cell, and 2 is the part of the antibody that attaches to the immune cell, the T cell. It activates the T cell. It brings them together, decreasing what we call the immunologic synapse. It brings them together, and that T cell that's activated, that's right next to that myeloma cell, will kill the T cell. The T cell will kill the myeloma cell. And so I'll just show you a little bit of data here. You see in this study, almost 2 out of 3 patients responded. Response happens very quickly. And when response happens in this, about 2/3 of patients, on average, it works for 18 months. And I think I'm at my last slide. We have a lot of, that's just what's approved and just what we have available. I have 15 clinical trials, and we have at least 2 more targets. We have new antibodies. We have we have 8 different bispecifics. We have ways to make bispecifics better. We have ways to make bispecifics work longer. We're trying to figure out how long we should give bispecifics, all of these things. We talked about earlier, not every relapse needs to be treated right away. Lots of factors we go in there. We have more drugs and combinations coming. Please, if you have access to it, participate in clinical trials. Every single drug I showed you, the only reason we have access to it in the clinic is because somebody participated on the clinical trial. And we appreciate each and every person who bravely does that. If your doctor's not talking about clinical trials, then talk to the doctor about clinical trials. And I have a lot of hope and promise for the future. And with that, I'm a minute over time, and I want to thank everybody for their attention. So thank you.
Well, a minute now. You did a great job, Jonathan. I really appreciate it. Mechanical, go back to his slides after the show. Jonathan's charts and Rafat's charts are very important to your treatment. It might simplify it, but the big question I have, who names these drugs? It's so confusing for people.
So
help me there.
I'm working with it. There's some names that are required. The FDA says you have to name, like the generic names are technical names that have very limited options. The brand names, Revlimid and Velcade and Kyprolis and Carvykti and Abecma, those are made by the marketing department.
I see. All right. Well,
Not
they
the
are
scientists.
interesting. No, they are interesting and very confusing for some patients. But I appreciate what your doctors do to explain it. How about that CAR T, people? That's amazingly interesting. And I think only a few centers get to do it, or there's only a couple of slots. Is that right, Jonathan?
Yeah, so a lot of centers are doing it, but we're limited on the slots. And we get about 4 slots a month between the two products, and we meet as a group every week. And I find out about slots in February for April. So I've got to figure out who can be okay until April. And so we as a group, there's, I don't know, 5 or 6 or 7 of us. We have our patients, we have our slots, and we try to match these as much as we can. The good thing is now that we have teclistamab approved, it takes a little bit of pressure off of us because patients who need treatment, who've had 4 lines of therapy, who need treatment today, can go on teclistamab. There are some patients, and again, we talked about this relapse. Some patients who have slow relapse, you can say 2 months from now, you're going to need a CAR T cell. Other patients, if I waited 2 months, they wouldn't be able to have any therapy.
I see. Let's see. What about off-the-shelf CAR Ts?
Yeah.
Is that real?
So right now we're using CAR T cells from our own body, what we call autologous, and there are currently off-the-shelf or allogeneic CAR T cells in development in the clinical trial phase.
I see. And now, have you guys heard anything about insurance for CAR T? That's a couple of questions about that.
Yeah, insurance approves CAR T.
Okay, good.
I don't know about your insurance, but insurance approves CAR T for you have to submit the paperwork and you have the right indication and it's approved.
Okay, that's great. Rafat, would you like to? I noticed you were reading some of these questions. Is there anything you'd like to respond to?
No, I mean, I think, Jonathan is quite comprehensive. I think, the issue is with CAR T cells, the availability. Some institutions like ours are unable to provide it to Medicare patient because of the cost, unable to recover the cost for that. So, it's a great drug, but it's not really a drug yet, because it's not available to me when I need it. When I drug you have a patient relapsing, you need to treat them, you get authorization, you treat them next week, if not next day. CAR T cells, as you heard, you have to get a slot, you have to get evaluate the patient. Then you have to send the cells to be manufactured. So you're going 3 months trying to find a way to control relapse patients. Sometimes we're not very lucky, so I think that's important to remember. But hopefully the off-the-shelf CAR T cells will become a reality. And, there are also research, not with just CAR T cells, but natural killer cells and off the shelf. And we have a trial like that we're participating in. So it will be interesting to see what the future holds for CAR T cells and NK cells when you have tons of bispecific T cell engager.
I think that off-the-shelf concept is just fascinating.
One and done.
Yeah, I've heard other doctors said that. I mean, it's just outside of these terms all sounding like you're in Star Wars or Star Trek. You hear CAR T and you can hear some things there. I think that
the science is amazing. It's so beautiful.
Yes.
I mean, I love science. I love the way the T cells work with bispecific T cells and CAR T cells. amazing stuff.
Yeah, yeah. Well, Dr. Kaufman and Dr. Abonour, thanks for answering questions. And Jonathan, excellent presentation.
Thank you, Kelly.
Everyone lift your arms up and stretch a little bit. We're going to go into the canvas one with Dr. Verena. I've worked with him several times, and I really like his presentation about this. It kind of gets into the nuts and bolts of what you're going through, and he's very good at it. So take it away. Are you muted?
Hey,
there we go.
After 3 years, we still don't know how to hit the mute button off when we start presentations. So we're going to try that again today. I think I'm moving Dr. Kaufman's slide. Is that all your slides?
Yes, yeah, there you go.
There we go.
Okay, there we go.
Life is a campus, and you're the artist.
Life
There
is a
it is.
campus and lots of extra PowerPoint slides. But definitely thank you for everybody just to keep us rolling and just wrapping it up for the rest of the evening. I know it's later for me on the East Coast, but earlier for everybody else. But love to talk about, myeloma. And I think, when I went through this presentation, and this is the color wheel and life as a canvas, I actually had a flashback to the Partridge Family bus. So it really was kind of like seeing all these colors and understanding what's going on, but really understanding, and it was wonderfully illustrated by the two physicians prior to me. Myeloma to me is a wheel of color, and it changes. It's like a kaleidoscope. Every time you turn the wheel, it's a new patient, a new relapse, new color, new treatment. So I think really where we stand in our period of time with treatment is a wonderful time. And I'm going to just discuss briefly today, where we stand as patients and what we should be doing with ourselves. And if my button would work, this is why I don't do technology. Does anybody have technology? There we go. Okay, sorry about that. So really looking at the treatment options, I think it was beautifully, like I said earlier, illustrated what we presented at first diagnosis or induction therapy, and really looking at patients with relapse and then clinical trials, which is so, and I think all of us cannot say enough the importance of participating in clinical trials, and with clinical trials and with treatments, symptoms management, and really looking at supportive care. And we said, what is myeloma treatment? Is it rapid and effective disease control? We've said that earlier before. Durable disease control. How long can we keep the disease away? We talk about progression-free survival, and many of us have said that it's, currently, right, it's incurable. We can get into a functional cure where patients are in deep remissions for long periods of time, but we know, I make a joke like crouching tiger, hidden dragon. Sometimes there's a small cell hanging out and eventually it does rear its head. We want to look at minimizing side effects. Myeloma is a disease of the more mature adult. I never say older because I'll be there, so I like saying more mature with age. But we do see younger patients coming on, so we want to minimize some of the side effects because some of us do have other comorbidities, hypertension, maybe diabetes, so things that we need to manage prior to starting treatment and while on treatment. And really, I think in this day and age, allowing good quality of life. And that really is, we're more active now. We want to travel. We want to see the world. We want to do things. So what can we do to keep you as active, still working, and right? Seeing your grandkids or travel, improve it. Really our goal in myeloma, and I think we all can agree what we used to see in the past, our overall survival rates have grown tremendously with the induction of immunomodulator drugs. And then now with looking at adding our monoclonal antibodies, and now seeing really the new with the CAR Ts, and we'll really see the bigger effects of as we move forward with the teclistamabs and those two drugs. And really looking at supportive care, and I think that's important, is prevented disease and treatment side effects. And we'll talk a little bit about that. And optimizing side effects, really. I always say, it's not doctor knows best. Really, it is a shared decision. So it's important as a team with your healthcare team ourselves, really discussing how you feel on the current treatments. There are other drugs that may be able to help minimize some of those side effects to keep you on it. Like many of the presentations, the longer patients were on therapy, like the DARA VRD, the longer you are on therapy, the deeper the response. But if you're having side effects, stopping the therapy, we really want to keep you having a full treatment, the best response as possible. I'm not going to go through that because I think we talked about it quite earlier, induction therapy itself. But we want to look at when patients really looking at what are the best patient reported symptoms when they're on therapy, even sometimes prior to starting therapy, what may impact our quality of life, right? We talk about physical side effects. We're literally thinking about, fatigue. Now, I joke a lot with people. I think if we took a poll right now, the whole world is fatigued at some point. We're always tired. Ask any of your friends, how do they say, oh, I'm tired, I'm fatigued? But sometimes we really need to take into account what fatigue means to you as the patient or even to your caregiver, right? I have patients that ride their bikes just like everybody else does. They'll say, I rode 20 miles, but I felt very tired, but because normally they would be easier for them. Constipation, we have to think about, oops, sorry about that. Neuropathy was mentioned earlier, that pins and needles. So again, you may have it from other comorbidities, or was it drug-induced? And sexual dysfunction. I think sexual health and sexual dysfunction should be addressed a lot within the clinics. With these symptoms, and sometimes symptoms alone, maybe neuropathy or decreasing quality of life may bring on, depression, anxiety. Many of our drugs do give, sometimes steroids can do sleep disturbances. So not getting the best rest might add more fatigue, which makes you more depressed and having anxiety for having your treatment. Sometimes there's cognitive impairment, right? And then really, I think where we stand internationally in the world of with our treatments that are available is financial burden and financial toxicity. And that's something that we need to take into account when we're thinking of what the best treatment upfront or even at relapse for the patients and what is the burden of those things going forward. I think sharing an auto stem cell transplant, we talked about that as an option. And I think we did say it very eloquently earlier on in this presentation that it's not off the table. I know we've been debating it for many, many years. I always consider it is like the great debate because nobody knows when to stop doing an auto transplant, but it is still part of our data. So it is no black and white answers whether to go under an actual transplant, but many trials are trying to say, should we do a transplant if you're MRD negative? Do you hold off and monitor, or do you go forward if you're MRD positive? And really, what is a commitment to the transplant? It's to both. It's not just the patient. And I think many commercials have been eloquently stated that when they say she has prostate cancer, or, it is the family, it is the caregiver, and it's the patient who actually carry the burden of the scarlet letter of maybe the C on their chest, and not just the patient themselves. So really looking at the burden across the board and how we can support both teams I think are tremendously important. And understanding the actual process of it. We talked about CAR T cell, and CAR T cell, the process is very similar. It's a different cell that we are actually harvesting. But again, the CD38, the CD34 cell is what we're using for the actual transplant itself. So really a decision is looking at patient preference, the data from the research, and really clinical experience from the teams they have. Not every institution does CAR T cell, does stem cell transplants, but we refer to an institution that are experts in it. Let's talk about some side effects. And I know it says the bright and the dark side of steroids. And I think that's the best concept of it. It is a yin and yang. I have patients who love their steroids because they have the best time. They're awake, they feel the most alert, and they get the most done. And then I feel that there's a group of patients who do not really enjoy it because it makes them have anxiety. They don't get to relax, and they have these highs and lows. They have these peaks of excitement, and then they drop after the steroids wear off. So again, they have their place, but also steroids do have other side effects to them. So it does cause It can cause difficulty sleeping, insomnia, or fatigue, increases risk for infections because it can suppress the immune system. But steroids has always been the base of myeloma treatment. It is anti-myeloma in killing. So again, looking at that, it increases blood pressure or water retention. Nobody likes to feel bloated, but it's important to keep in mind, why we're doing a weight gain is important, stomach and bloating, and again, increases blood sugar. So again, like I said earlier, if you have a history of diabetes and putting you on steroids might raise your blood sugars, again, it's a collaborative discussion between your healthcare team, plus your endocrinologist and things like that. So again, when you take your steroids, again, I have patients who actually say, I like to take them late at night because when they finally kick in, they're wide awake in the morning. Some patients choose to have them in the morning. So again, it's another discussion. Think about medications to help prevent shingles, thrush, and other infections, because again, with some types of immunosuppressive, and steroids may increase your risk of developing those particular diseases. Myeloma, I said, in infections and side effects and management is something important. We always talk about infections. BCMA target therapies, like we said with the CAR Ts, are associated with high risk infections that we have seen. Up to a third of patients on clinical trials had serious infections, which were including IV antibiotics or hospitalization. So again, we're slipping out of the pandemic. We've been living in this COVID world for quite some time, but it is still there. COVID is not going away. So we know it increases serious COVID complications despite history of vaccinations. You could have 1, 2, 3, 4, or 5. And we know patients with many other research showing that the patients, even with COVID vaccines, have a lower response because they're on suppressive therapies. We want to monitor their antibody levels. We do know that there are some therapies once you are COVID positive. We do know there's still EvoShield is still available. And we do know that Paxlovid is actually out there too. So within 5 days of diagnosis. But very important about Paxlovid, it does interact with many medications that you may be on for other comorbidities or other disease processes. So again, you must talk to your pharmacist and your clinical team to really discuss that and what's the best treatment. And again, if you are on these BCMA-directed drugs and you may have low immunoglobulins, sometimes other institutions, we do use intravenous immunoglobulin, so IVIG on a monthly basis, sometimes during the winter months or even while you're on the therapy, to help make your immune system a little bit more robust and try to limit the risk of infection. It still may not prevent it, but it may help delay it. Again, infections can be very serious. 7 to 10-fold increased risk of bacterial and viral infections that we see in patients with myeloma. And this is not including what I just talked about with the BCMA-directed therapies that we've seen. So again, important to always contact your physician when you're not feeling well. If you're on immunosuppressive drugs, you may not always induce a fever of 100.4. So if you're not feeling well, if you have chills, you want to call the office. Or if you do have a fever of 100.4, you call them immediately, or shortness of breath. How do we prevent this? And I think things are important. I think we've all become very good hand washers since the COVID pandemic. I think we've put more Perel out there than we used to use when we used Dippity Doo in our hair. So it's pretty much out there. So good personal hygiene, skin and oral. Should be always seeing your dentist at least every 6 months. Environmental control, wash your hands, avoid crowds or sick patients when you're on therapy. Again, keeping it, I always say, be mindful of your environment. I don't believe in isolation. I think being mindful and not going into let's go to the Rolling Stones concert, and I just had my therapy yesterday. I don't even know if the Rolling Stones are still around. I'm just joking. Look, everybody's like, oh my God, no. But it's still there. If you have therapies and your white count may be low, there are growth factors that help improve those to keep your robust immune system. Immunizations are very important. So getting your yearly flu shot, staying up on your COVID vaccines, your pneumovax, again, very important, but no live vaccines. And medications such as antibacterial or antivirals as prophylactic medications are very important. I always say, I love the strategies of prevention, stress management. I think we all could sit here and stare at each other. What's the best stress management? We had a wonderful relaxation session earlier this evening, but it is time that we have busy lives. And I think even as healthcare providers and as the patients and the caregivers, between so many appointments, going to your cancer doctor, have to go to your endocrinologist, got to go for a test. When do we have time to actually rest? Then I give you steroids. Do you have time to rest on steroids? And I always think steroids are great because, either the houses are very clean or there's a very high divorce rate. It's an option on either side of the scale. But again, we have to figure out how to rest and relax, create a sleep hygiene. I know we like to watch and binge watch everything on Netflix now to 2, 3, 4 a.m. in the morning. But it's important to say, I need to go to bed the same time every night, and I need to wake up at a reasonable hour to get this sleep. Mental health or social engagement. I think, I will be very honest from my perspective. When you looked at the pandemic, it created isolation. I think it caused a lot of psychosocial stresses across the board. And I think it's time, again, being mindful, but re-engaging in social engagements, going out there, seeing some friends, being able to talk to people. We're all right now, and I would love to be live and sitting here talking to everybody, but we're all very Zoom related, right? I think we're done. I would like to have, we're like zoomocytosis. I'd like to have zoonopenia. I'd like to be in Zoompenia land and have less Zooms as much as possible. But complementary therapies, sometimes people, and again, I always say complementary therapies are important to talk about when you want to speak with your healthcare provider. Are there alternative medications? Sometimes I recommend, and it's all in conjugation as a group, like melatonin, something that helps relax you or not. Weight gain, I think it's not even it's not the 20-pound freshman, it's like the 30-pound COVID. But again, weight pain and having on steroids, looking at best nutrition, getting back out there and exercising. I would say from the East Coast standpoint, we had the most mild winter we've ever had in a long time. So I think we were outside more than I would say Midwest, where you all got the snow. Thank you very much. I appreciate that. But staying active is possible. Preventative healthcare. I am your healthcare provider when it comes to your myeloma. But it's important that you do go see your primary care doctor, you see your dentist, you see your gynecologist. You want these health screenings, staying on top of these vaccinations, right? Preventative falls, make sure your houses don't have loose rugs, or if you feel unstable, have the right devices to help you prevent from falling and having injuries or risk for infections. Big thing, stop smoking. I know, I mean, I used to remember the little dragon that said stop, drop, and roll. But I mean, it's important that, smoking does increase your risk besides from other cardiovascular diseases, but it also interferes with many of the medications that we may give. So it's important. And dental care, we talk about that. We'll talk about it a little bit later. We talk about bone strengthening therapies that are out there. So good, healthy dental care is important because some of these medications may interfere or cause damage to the jaw, osteonecrosis of the jaw. So again, keeping that up there, and hydration, and avoid renal toxic medication. I think earlier we said that, myeloma loves bone, but it also loves the kidneys. It's its two favorite homes. So you always want to be careful of, any kind of drugs, stay away from NSAIDs or anything that's renal toxic. Hydration, drinking water. I know I'm a coffee fiend, so it would definitely be a little twitchy if I had to cut back on coffee. But again, drinking more fluids and water than actually drinking too much coffee, and diabetic control. And then your normal vitamin D supplements, and then weight-bearing exercises, like I said earlier, I think is important alone. What I think, in segueing here, and I think it's a time to take a pause for a moment, is we talk a lot about the healthcare providers and we talk a lot about the patients, but I also think the partner support is extremely important. They may be the ones that taking everybody to the appointments, they're always, I call them the truth serums in the room, because there are patients that just literally they stare away from me, or they say everything is great. And then I always say the truth serum speaks, and they hand me an entire dossier of what's been going on with the patient over the last week or two. So again, the care provider, the care partner plays in, you guys, I say it all the time, the caregiver plays such an important and central role in providing the care for your loved one that's with you. Again, important keeping there, making sure the patient understands what's going on, especially when it comes to transplants, with it, whether it's a stem cell transplant or it's a CAR T process, right? Sedative procedure, education sessions over and over again. We all got into healthcare for a reason, to care and give education. It's always reinforcing the importance of both. And I think the healthcare provider and the support groups are extremely important, especially from the IMF. It's pretty there. Persons are important ourselves. And I never can push the button the right way, because I am old. I can say that. There we go. GI symptoms. I'm going to go through this quickly because I have 3.5 seconds always at the end of the day. No, but preventative GI symptoms, many therapies that we give may cause diarrhea. So again, make sure, if you're taking laxatives, slow down on the laxative. Antacids with magnesium can cause diarrhea, antibiotics and antidepressants. So again, always monitoring exactly what you're taking may cause it. But in the reverse is that many of our drugs, anti-emetics or anti-nausea medications, may also cause constipation. So again, and even opioids. So again, you may have to be on some type of constipation bowel regimen. So again, I always say bowel regimens are very personal. Again, knowing your own body when you have bowel movements, everybody thinks it's every day, or some people go every 2 days. But again, monitoring that. But even if you're not on laxatives and you're having symptoms like diarrhea, always call your healthcare providers. Again, stressing the importance of that open communication back and forth. Avoid heavy caffeine, carbonated, or heavily sugared beverages. Can also cause diarrhea, so you can take in consultation with your healthcare team, talking about some type of antidiarrheals, Imodium, fiber diets, and Welchol sometimes is recommended, because sometimes even some immunomodulator drugs just cause diarrhea on their own. And again, increasing your fiber, which I always talk about, and I never do, because I think I'm more like Amber. Brown food tastes good, and the green scares me, but stay on the fruits, vegetables, and high fiber is very important for our patient and for you itself. Pain is definitely important in prevention and in management. It is definitely, we talked about fatigue, tiredness, and I would say sleep deprivation or poor sleep habits. Pain is one of those that can cause compromising of the quality of life. And the source of pain could be the bone, it could be neuropathy, or even just the procedures that we go through for helping, monitoring and evaluating patients. So again, prevent pain whenever possible. You want to use that bone strengthening therapies that are out there. But again, the dental health is important, doing that prior to starting it. Again, interventions depending on the source of the pain. As we said earlier, patients will present with bone disease. It could be a fracture. It could be a compression fracture of the vertebral or something, or even in the actual arm itself. So again, knowing the source of pain. If we have to treat it, we can treat it with radiation or use opioids or therapies. At my institution, we have a supportive care department that actually helps support our patients and keep them as pain-free as possible. And then do imaging when needed. So MRIs, PET scans, CAT scans, without contrast are extremely important to evaluate where the source of pain is, and is there any way we can interact with that. But again, pain can be very depressing. So can peripheral neuropathy. It's that numbing and tingling. It could be that feeling of wearing socks when your feet are barefoot. Some people feel like they're walking on bubble wrap. They cannot always tell, sometimes hot or cold, or sometimes their feet are always burning hot. Again, something you want to always report back to us as teams. what it can be from it could be from other disease processes, not always in myeloma, but myeloma does also sometimes present with peripheral neuropathy. It can be from bortezomib itself. So we talked about that earlier. One of the major side effects is peripheral neuropathy. We've seen it actually decrease due to the fact of giving it subcutaneous or in the skin, but it still exists. And even in carfilzomib and even the oral ixazomib, we've seen it actually occur. How do we sometimes decrease or prevent it? We do bortezomib once weekly and give it sub-Q, and massage the area with cocoa butter might also be helpful itself. And then again, you can use supplements, B complexes, folic acid, or amino acids while on the bortezomib itself. But again, always, I can't say it enough, always talk to your healthcare providers before stopping your therapies or just adding herbals to your medications, because many herbals can interact with other westernized medicines themselves. Wrapping it up, really looking at fatigue and depression. It's extremely important that, most patients, about 98% do report some type of fatigue. The source could be anemia, it could be pain, it could be from therapies that we are giving. Again, insomnia or treatment or toxicities of bone marrow suppression. Understanding, always keeping that open dialogue. Anxiety is reported. Over 35% of patients have anxiety. And I think anxiety always comes from, and as we said earlier, there's that MGUS or smoldering group. Even without treatment, the anxiety of coming in to seeing myself or your healthcare providers, then knowing what my results are, what is the next step, or even if we have that biochemical relapse, and walking in the door, what are we going to do? What is the next step? And then researching. Dr. Google doesn't always give the best advice, but it's important to talk to the right people. So again, anxiety and depression come hand in hand. So again, talking to everybody. And then financial burden. It is, the medical costs have become astronomical over the years, right? Premiums, co-payments, travel expenses, and there's also time toxicity. If you think about it, the amount of time that we take to travel from your home to your institution. I live in Manhattan, and let me tell you, it could take still an hour and a half to get from, go 30 blocks down. So again, and then you have patients like yourselves that may be living 3-4 hours away from the nearest cancer center. So again, that's also a huge burden. Medical supplies, the simplest things, lancets, alcohol pads, prescription costs. What's their copay on prescription costs? Loss of income because your time toxicity, right? You're traveling, you're coming to the institution. You may spend 3, 4, 5, 6 hours each time, 2-3 times a week at the institution. Important to talk to, and I always say this, really talk to, if you have a nurse navigator at your institution, talk to the social workers, reach out to the pharmaceutical support groups. There might be, institutional funding or from even nonprofits that are available for you to subsidize some of or offset some of those extra burdens or costs going forward. And, every time I push the button, I'm just going to keep smiling, because I think that's always better. Okay. And then last but not least, I think I'm just going to end. My pictures are not there, and neither are ours. And I think we should have planted ourselves in there. But knowing that really you are part of the team. It is not doctors know best. Remember, fathers knows best, but it's not doctors knows best. It's really a full team. We're here to support you. So really your whole team is your pharmacist, your PCP, your specialist, your allied health, your support groups, going to these support meetings and talking to others that may have the same issue again. And then your myeloma specialists are really part of your whole team. So everybody says it, but I really do. It's true. It takes a village to help care for a myeloma patient. It is not just one person. It's your caregiver plus the entire team around you, which I think is extremely important. Again, we've moved towards televisits. Always come prepared. We're having a televisit right now. Thank you very much. I probably just charged you $1. But importantly enough, that, be prepared with the list of medications because you can't hand it to me in front of me. Have a list of questions always prepared. I think that's important. When you think of something, don't say, oh, I'll remember it when I talk to my doctor. Trust me, I can't remember what I just did yesterday or just I did 5 minutes ago. So put it on a pad, have a book, have the caregiver write it down for you, any symptoms that are changing. So when you are with your televisit or an in-person visit, you're able to express the concerns that you've had over the last week, or even if you don't see each other for 2-3 weeks or 4 weeks, really come up and understand that. And then always ask the question, what happens when I relapse and what's the next step? And again, and we talked about it heavily, clinical trials. Is there a clinical trial for me when I relapse at this stage, or what's available? Always kind of saying, not wishing you to relapse, but kind of planning ahead, saying, here's my next step. If this happens, here are your choices. This is the buffet, the candy box of Valentine's, but you only ate 3 because you probably squished your thumb into 4 of them. But here are the candies that you have available. Here's how we're going to move forward. So again, always being prepared and having that open discussion with your entire team. I said that it is a shared decision making, and that's all. So again, reach out to the IMF info line. I think I love to plug this, but I am on the Nursing Leadership Board, and I think it's important. We have a tremendous amount of information for you and your caregivers and your family about therapies, about the drugs that are available, and even the support groups that are out there, whether they're in person or actually in a webinar or a tele kind of version of it. Definitely participate in all of that. And I think I am so over every time I do this, and you're not alone, because I'm never alone because everybody's here on the board. And I want to thank you for your time.
Yeah, that was great. I always appreciate the Nurse Leadership Board's presentation. I think everyone that took notes need to review the whole program as soon as possible so you don't forget things. We're running a little tight on time. Let's see, we'll go to the next slide. And question and answers. It's kind of a little late right now, but you'll be getting a notice saying you can get this back to you. One person asked a lot of questions. I suggest that they go to 800-487-CURE. Let's get someone to handle your questions. And with that, let's see, where's the next slide? That's it there. Thank you for joining us. I'd like to thank our sponsors once again. They are coming up, AbbVie, Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Santa Fe, and Takeda. Without them, and without these doctors, and without the nurse, none of this would be possible. And they have done a heck of a job today. There was a lot of topics to cover. And Daniel, I know you got to the last part, but it's okay. You went over because what you were talking about was incredibly important. So with all that being said, we'll look for your email to go back to this so you can look at it at your own time. And always remember, myeloma.org. And I forgot, I noticed on here, the Connecticut support group with John Patrick and Robin Toohey and Michael Toohey were watching this today. Thank you very much. And thank you, everyone, for showing up tonight. It means a lot to us.